Sağlık politikaları hakkında sunumunu yapmak üzere İngiltere London School of Economics'ten değerli Profesör Doktor Sayın Elias Mossialos'u ve oturum başkanlığını yapmak üzere Profesör Doktor Sayın Hasan Hüseyin Yıldırım'ı kürsüye davet edelim.
Teşekkürler. Good morning, ladies and gentlemen. We are pleased to welcome Professor Elias Mossialos, a distinguished professor from London School of Economics. I would like to introduce Elias to briefly. Elias Mossialos is a professor of health policy at the London School of Economics and Imperial College London, inaugural head of LSE's new Department of Health Policy, and founder and director of LSE Health, a research center with 60 staff that last year won a major role in a pan-European project on using big data to improve health outcomes. He is also the co-director of European Observatory on Health Systems and Policies. This is considered to be the largest knowledge transfer program in the world. It is founded by several European governments, including the WHO, the European Commission, the World Bank, and the other governments. He has developed the options market for antibiotics, an incentive scheme to stimulate research and development, and his recent research on cancer drugs found that 1 in 3 licensed in 2003 and 13 produced no hour survival benefit. Professor Elias Mossialos is highly regarded as a world leader in his comparative work on healthcare financing and his research on EU law and governments. In 2010, he was awarded the Andrija Stamper Medal by the Association School of Public Health in Europe and European Public Health Association for his contributions to the European public health. In 2009, under his directorship, LSE Health was honored with the biennial Queen's Anniversary Prize for Higher and Further Education. And then he received the 2002 and 2007 Baxter Awards from the European Health Management Association for the best publication in health policy and management in the European, and commanded prize in 2002, the British Medical Association Medical Book Competition. Professor Mossialos has led the health policy work of 5 presidencies of the Council of the European Union, including Belgium, Sweden, Netherlands, and currently the Austria. And the last, I think the most important, Professor Mossialos has just started work as chair of the Lancet Commission on the future of the UK NHS. And please take a seat. Thank you very much.
Good morning. Thank you very much, Hassan, for this very kind introduction. I would first like to thank Professor Fakhrettin, President of TUSEB, and TUSEB for their kind invitation to participate in your very prestigious and important conference. And congratulate you also on your important National Day today. Let me start by briefly presenting the key elements of my presentation today. The key elements are going to be a reference to key challenges and problems in healthcare systems we're faced with and how we can solve them. Then I will move on to discuss what is big data in healthcare, how we can use big data in health to improve population health. I'll give you some examples on how we can do this, because we have to be practical, not just explain what is happening in health systems in the world, but come up with practical solutions. And finally, I will outline a way forward with some caution, because we need to take into account some complexities involved when we're analyzing big data. So why are we using big data in healthcare systems? The most important element is we need to measure and improve health systems performance. So we should always strive to do better and improve the quality of our healthcare systems. And I have to say here that Turkey has made important improvements in the delivery of healthcare services, but also in healthcare coverage. So in the past 10 years, you are a world example in terms of expanding coverage for all Turkish citizens. So you've managed to achieve universal health coverage for everybody and good access to healthcare services, and increase the supply of both hospital services and primary care services in your country. As a result, life expectancy in Turkey increased from 59 years back in 1980 to 76 years in 2016. This is a huge and tremendous achievement. And you're offering universal health coverage to your citizens at a very low cost. You're spending less than 6.5% of your national wealth, of your GDP, to offer good access to healthcare services for all people. Now, compare this to the 18% that the United States of America is spending, almost 3 times more than Turkey, and they still have 20% of their citizens uninsured or with partial insurance. So your achievement is a tremendous achievement, and you should celebrate it today together with your National Day. It's a very, very big step forward for Turkey to have achieved such an important gain in the healthcare system. We're also using big data to improve patient care. And I think the previous speaker, Professor Emre, the transplant surgeon from Yale University, he referred to techniques on how we can improve the quality of the organs. So kidneys, for example, by using perfusion techniques. But we can also use big data and artificial intelligence and big data analytics and machine learning to improve the delivery of kidneys. In the country where I work, the United Kingdom, 50% of the kidneys are wasted because the doctors cannot tell if the kidney is of high quality. They consider them to be high risk. But the variations across centers are tremendous. So at Imperial College, where I work, at the Hammersmith Hospital, where I run a center for health policy, we're working together with the transplant surgeons and the kidney experts to develop artificial intelligence and machine learning systems so that we can help the doctors to identify if the kidney is high risk or low risk. And by using artificial intelligence and machine learning, we have reduced the number of kidneys which are rejected from 50% to 10%. But in other centers, the rejection rate is 70 or 80%. As a result, because doctors feel uncertain, as a result, quite a lot of kidneys which could have been transplanted to patients who are suffering from this dreadful kidney disease and have to be on dialysis for many, many years. As a result, their life expectancy is compromised. By using big data and artificial intelligence and machine learning, we're improving patient care. We can also use big data for cross-country comparisons, not just look at a superficial level, how much we're spending on healthcare, but look at survival rates for cancer patients. We can look into what is being done for each patient in each country so that we can learn from the experiments of other countries to improve patient care in another country. Use this big data for R&D improvements, for working together with the biomedical industry, the bioinformatics industry, and the pharmaceutical industry to improve R&D and reduce the cost of R&D as well, because we're spending more than $2 billion to discover a new medication, and the cost has been going up. It used to be $1 billion back in the 1990s. But also use the big data, pulling together data from clinical trials, also observation and epidemiological studies, real-world data, to identify the value of new medications. And going back to the cancer medicines, we recently published a paper in JAMA Oncology, where we analyzed data from 3,000 different clinical trials and 2,000 epidemiological studies. And we came up with the conclusion that about 1/3 of the new cancer drugs that have been authorized by the US FDA between 2003 and 2015 are not actually better compared to existing alternatives, but they cost 50 to 180 times more compared to the drugs we have available. So therefore, we need to use this big data not only to improve R&D and help the pharmaceutical industry to produce new drugs, but also to hold accountable the pharmaceutical industry if they don't really produce new drugs and they overcharge our healthcare systems. And finally, we need to have big data in order to improve decision making. So the health ministers should know about what is happening in the hospitals in Turkey. For example, if there are hospitals where there is a significant number of readmissions, and again referring to the United States hospitals, 1 out of 3 patients in the US is readmitted to a hospital within 30 days after they have been discharged. And of course, not all readmissions are unnecessary. Some readmissions are necessary because you need to get back to the hospital to do another procedure and operation. But 1/3 is quite a lot, but again, even in the US, the variation is tremendous. In some areas, readmissions count for 10% of total admissions. In other areas, count for 40% of total admissions. It will be good, therefore, to have big data to know as to what extent all Turkish hospitals perform at a high quality level, and also to be able to tell the difference between the factors that could contribute to the readmissions. It could be the hospital, it could be the patient not taking his medication, or it could be the lack of primary care or lack of coordination between the hospital doctors and the primary care doctors. Now, in order to extract the greatest benefit from big data, however, we must identify first the current problems. It's good to have big data, but without identifying the right problems and the current problems, and ask the right and the correct questions, we cannot determine what data is needed. We will suffer from information paralysis. We'll be collecting everything. So the collection of the data should be linked to the identification of the big problems in the country and the problems we are trying to solve, and then try to fill the gaps. And the size of the data does not matter if we do not know how to properly organize and analyze it. And you may say, what is the big value of big data in clinical medicine? The big value is that we need to reduce type 1 and type 2 errors. So if we have better quality data and more data, we can easily identify false positives and false negatives in the diagnostic process. And this is the usefulness for the clinical profession. If we manage to provide them with accurate information in terms of the diagnostic process, we're going to save lives and also protect patients from medical errors as well. There are 5 different streams of information we can analyze in order to get high quality data. We can use web and social media data. Now, many people are collecting data from Facebook, from Twitter, from health plan websites and smartphone applications. This is quite an anarchic process, I have to say. But many important interventions have been based on Facebook data. For example, in England, we're using Facebook and Twitter data to identify depression, particularly for select populations which are considered to be high-risk populations. So you can analyze the text, the messages in Twitter, in Facebook, and identify potential suicidal behavior and prevent it. So there could be good uses of big data coming from massive sources such as Twitter and Facebook or smartphone applications. Then there are the machine-to-machine data, readings from sensors, from meters and other devices. The big transaction data, and here you have a single insurer which is collecting all the claims data from all your providers. And this is very good. It's one of the biggest data sets in the world, the Turkish claims data that your Social Security organization is collecting. And will be important, Professor Fakhrtin, to convince the Social Security institution to make this data available to your scientific community, because this data is not available now to the scientific community. It's only used for administrative purposes. But if this data is used for academic and scientific purposes, you can come up with very interesting academic work within TUSEB. And then you have biometric data from genetics and fingerprints, and then the human-generated data, the electronic health records, and I think previous speakers emphasized the usefulness of electronic health records, and I'll give some examples now. Now, before I proceed with more examples, let me first refer to the key problems we're faced with in healthcare systems, and these are universal healthcare problems. The major problem is that we're treating our patients too late. The healthcare systems have been structured in a way that our doctors are waiting in their offices for the patients to turn up. So our hospitals are waiting for patients to be admitted. Pharmacists are waiting in their offices again for the patients to go there and pick up their medication. We're unsure of what does work. We treat all people in the same way, independently of whether they may suffer from different conditions, and there are different levels of severity for diabetic patients or cancer patients. Medical errors and medical mistakes are often not noticed. And I have to say here, most medical errors happen because of system problems, not of individual factors, not because doctors are making mistakes. It's only 5% of the medical errors that can be attributed to a human factor. 95% of medical errors happen because the system is not well organized. But we don't take care of improving health systems to focus on reducing the errors. There is variable quality of healthcare across providers in all healthcare systems in the world. Not only hospitals, also individual doctors perform at different levels. There are non-sensible workflows from one doctor to another, from one nurse to another, particularly in early hours, 6 o'clock in the morning or 7 o'clock in the morning, or late hours in the evening. Everybody is tired, everybody wants to go home, and they don't bother to communicate. We make patients arrive at our silos. The cardiology doctor will take care of the heart problem of a patient, the diabetics expert of the diabetics problem, the respiratory expert of the asthma. But there are many patients who suffer from many morbidities, from multimorbidities, and usually we don't have coordination across different types of specializations. And even doctors don't compare their notes, and there are no electronic medical records. The situation is worse. And I'll give you an example. In England, 50% of hospitalizations in England can be attributed to drug-to-drug interactions because people take 11 to 17 medications if they suffer from more than 4 conditions, and nobody cares. So the doctors don't compare their notes. Then the pharmacist should have been more proactive, but the pharmacists do not have electronic systems to compare drug-to-drug interactions. And that brings me to the point that the pharmacists can play a much bigger role in our societies, but also electronic systems and IT systems can help the work of the doctors. And finally, we do whatever we do, and people don't bother. Patients don't take into account our advice. So 50% of patients who have had a heart attack will give up medication within a year because they feel better. And 25% of them will pass away a year later. This is a huge waste for our societies. 50% of asthmatic patients give up medication because it's a periodic disease. So the asthma attacks will not come every day, but every probably 3 or 4 months. I have to say I'm one of those bad patients. I don't take my asthma medications quite often, and I usually have 1 attack a year. So ourselves, even the experts sometimes do not conform with the advices of our doctors. So what can be done, therefore, by using big data and healthcare systems? We can be more proactive. We can identify the high risk and the low risk patients and take more care of the high risks, and I'll give you an example of how we can do that. We can collect more data. This is the real world assessment that you have a lecture yesterday by Omer Sakar, how we can use real world data. But we can do much better there. Compile data from clinical trials, compile data from epidemiological and observational studies. It's not an easy thing to do because there are commercial confidentiality issues. So the pharmaceutical industry has signed agreements, commercial agreements not to disclose this data. They're patient confidentiality data. And sometimes even us, the scientific community, are not prepared to share our data with other colleagues within the academic world. So I've asked colleagues a few months ago from 25 universities to share with me their clinical trial data so that I could pull the data together and meta-analyze them, and the response rate was 15% from the academic community. So sometimes there is resistance also within the academic world to do that. We're treating all people the same, so medicine has to become more personalized. But if we are to become more personalized, this is when we need more big data and IT technologies to make the life of both patients and doctors easier, so that the treatments are personalized. We're not overdosing people with unnecessary levels of medications if this is not appropriate for their condition. Creating a safe environment in our hospitals. That means, as I said, not blaming individuals for the errors that are happening in hospitals, but identifying where the problems are. Creating decision support systems to reduce variations in quality. And finally, introducing more integrated systems across different specializations and consultations so people speak to each other and share notes. And finally, find ways to engage more with our patients, listen to our patients. And one of the biggest problems with readmissions is the discharge process. We don't spend time to explain to our patients what they have to do after they have been discharged from the hospital. We just give them a piece of paper. And if this piece of paper is also transferred to their primary care doctor, their cardiologist, that's fine. But on most occasions, we don't even bother to do that. And because people sometimes are not very educated, they don't even read this piece of paper, they don't discuss what they have to do with their doctor, and therefore more patient engagement, spending a little bit more time with the patient may save quite a lot of money to the healthcare system and improve population health. And then focusing on different population groups, we cannot consider that every single person in this country is the same. There are people who are healthy at a very low risk, and therefore we need to consider on how we can organize our preventative policies so that they don't develop diseases at an early stage. There are people who are at risk, so people who may have minor blood pressure, not very high elevated levels of blood pressure, and need to identify them, and their general practitioners and healthcare doctors should advise them on how they control blood pressure, or there are people at high risk with high levels of blood pressure, people with early clinical symptoms, they have headaches, so they're starting realizing that there is a problem. What are we going to do with them? Just wait for them to come to the premises of the doctor once they have the active disease, or incentivize our doctors through financial incentives or other incentives to identify disease at an earlier level and address it. But whatever we do, as Professor Emre emphasized earlier, this is not going to happen if we don't have good electronic health records. We do need to have unified health records across the Turkish healthcare system and all healthcare systems in the world. There's some good examples you can learn from other social insurance systems, such as the Dutch system, or systems which also focus on socialized approaches in terms of healthcare coverage, such as Denmark, Sweden, and the UK. And Denmark is the most pioneering country. Patients now can access their own electronic medical records, and these data are not accessible by insurers, they're not accessible by third parties. Each individual patient can download his or her medical record from the internet, and they have a very, very secure system in Denmark. And it has had a very positive effect on patient behavior. So people access their medical records and they have comparative data about the treatments they have received. This could modify behavior. But there is a lot of skepticism about the use of this big data. First, it's an academic skepticism. The right amount of data always trumps big data. So we should always try to use what we have and the right amount of what we have, rather than wait, for the year when we're going to have billions of data sets to take the right decisions. The public is very skeptical about the collection of data from different sources, from Facebook, from Twitter, from the doctor's offices, from utilization of hospital services. And they're very skeptical because they believe that this data might be released to the press, might be released to their relatives, to their friends, or also might be used by insurance agencies, particularly private medical insurance companies, to exclude them from coverage, and life insurance companies. And this is a big debate we currently have in the United Kingdom, because there have been some incidents where hospitals shared data with insurance companies, and then the big data prospect got very bad publicity in the British press, and there has been a big backlash. But look at this data, which is American data, and you might be surprised by this. 1% of our patients count for 22% of total healthcare expenditure, 5% of our patients for 45% of total healthcare expenditure, and 10% of our patients for 65% of overall healthcare costs. Are you surprised with this? That 10% of our patients cost 65% of the overall amount we're spending on healthcare every year. So it's a minority of our patients who are the high-cost, vulnerable patients. And this is why Turkey is pioneering and offering universal health coverage, because you're covering all Turkish citizens. That effectively means that 90% of the population in Turkey subsidizes, supports the high-cost, high-risk, vulnerable people in Turkey to have high-quality healthcare services. But if this is the case, and combined with the next slide, look at this. This is from big Scottish data, and we know that as we get older, the probability of developing more diseases increases. By the age of 50, out of two of us will have at least one chronic condition, asthma, diabetes, or heart disease. And as you can see, getting older is combined with having multimorbidity, suffering from 3, 4, or 5 conditions at the same time. So you present this data to the Minister of Health, and the Minister of Health gets terrified, goes to the Minister of Finance, and asks the Minister of Finance for more money. And then the Minister of Finance gets terrified. And how the Minister of Finance is going to think about. If he looks at this data, will say, oh, we're getting older, we're having more diseases, and the Minister of Health is asking for more money for the old people. If the old people live longer, the Minister of Finance is going to spend more money on pensions. So this is not good because the Minister of Finance is going to spend more money on health and more money on pensions. And then you need to present the Minister of Health with the next set of data. This is the Canadian data now. It's a very good data set from Canada. And what we get from this, that the prevalence of multimorbidity is not so much in older ages, but in the productive ages of our population. In the ages between 30 and 65, because we have more people suffering from multimorbidity in this age group. So the main argument for the Minister of Finance is, if we do nothing to protect the population health in this particular productive age group, then the Turkish economy is going to suffer. So multimorbidity, it's not only a problem of the very old. Multimorbidity, it's a problem of everybody who is older than 35 years old. And that's why we need to take care of the health of these people. And then you may ask, who is this 10% who is the high-cost, high-need patients? Look again at big data from the United States of America. We're talking a very small number of people. Less than 20 million Americans cost as much as 110 million Americans. Look at the category 4. Americans suffering from chronic conditions, which is controlled by medication or medical treatment. 110 million Americans cost $800 billion. And then only 20 million Americans, the high-cost, high-need, vulnerable Americans, cost about $760 billion. So that's why it is important to identify the high-risk people, because if we identify these 20 million Americans who cost a lot, we can control their care in a better way. We can offer them coordinated care, get groups of doctors to work together. I'm not saying that groups of doctors can work together for every disease, but particularly for the high-cost, high-need patients. And this is a project I'm running in China, together with the National Center of Cardiovascular Diseases in Beijing. And what we're doing in China, we have computerized all hospital admissions to Chinese hospitals. 130 million admissions in China every year. Remember, there are 1.3 billion people there, together with 8 billion outpatient consultations. And you can see the different mortality rates, hospital mortality for renal disease patients across the Chinese provinces. And the differences are huge. And then look at the diabetes associated with renal disease and gain in China. And again, the range is significant, from 6.6% to 38%. So this data is useful because then we can look deeper. Are there any genetic elements in different Chinese provinces that they lead to these huge differences? Or is it the quality of care that it is very bad in some Chinese provinces, particularly the western provinces, and this creates these huge differences from the eastern provinces, or more importantly, the southern provinces, where the prevalence of diabetes associated with renal disease is not significant. Then look at the next data. This is from the US. This is the level of microdata they have there in terms of 30-day readmissions to hospitals. Very, very micro-district data. And by using this data, you can see the differences within this American state are again important. Can you attribute these differences to the quality of the care in the different American districts? Or does it have to do with primary care? Does it have to do with patient characteristics? And then you look at this data, which is from Harvard University, and you can look at 30-day risk-adjusted mortality, taking into account comorbidities of patients after a heart attack. And you can see when a patient has 0 comorbidities, the mortality rate within 30 days is 9%, within a year is 15%. But when a patient has 4 cardiovascular comorbidities, the mortality rate within 30 days is 22%, and the mortality rate within a year is 53%. So why does it happen? Why does it happen that if I have a heart attack and have 4 comorbidities, my probability of dying is 53% within a year? Is it because of the care I have received in the hospital? Most unlikely, because this is one of the top American hospitals. Or is it because of lack of coordination between the doctors? Or is it because of lack of coordination between the hospital and the outpatient care doctor? Or the lack of coordination between pharmacy care, doctor's care at outpatient level and hospital care? And let me present some data from One of my colleagues, who is of Turkish origin, Hüseyin Nadzi, he's Turkish Cypriot. He's one of my most magnificent colleagues at the London School of Economics. He's only 32-year-old, and he's a big star. And I take very big pride on his work because I was his PhD supervisor, and he's now an assistant professor in my department. So what has Hussein done in the past 5 years in his research? He has looked at different statins. And you know that statins are used by all people having high cholesterol levels. And the common assumption when we're using statins is if we manage to lower cholesterol levels to very low levels, statins are better. The statins which manage to do a better job in terms of reducing cholesterol levels are better statins. So Hussein has studied different types of statins and different dose levels. And you can see here some statins are reducing cholesterol levels by even up to 60%. So they have been considered to be by both patients and the medical community the best statins, those who are reducing more. But then he did a meta-analysis of thousands of clinical trials and observational studies and considered the clinical benefits of statins together with potential harms, for example, side effects that these statins have, and came up with an interesting conclusion that the first statin, civanstatin, which is now a generic drug, and it is very inexpensive, is probably the best statin, rather than the latest versions of statins. So what are the policy implications of this big data analysis? Remember, this is millions of data brought together and meta-analyzed by a very competent Turkish researcher. The implications are tremendous in terms of healthcare costs, because civanstatin costs only £2 in England for a course of treatment of 28 days, and the latest statins cost more than £300 or £400 for the course of 28 days. So the cost implications are important. Let me conclude. In order to achieve a good healthcare system and have good quality data, we need to convince 6 important major stakeholders to work together, and this is not going to be easy. Providers to collect clinical and medical data through electronic health records. Payers and providers to combine the clinical data with cost data, because it's important to know whether an intervention is not only clinically effective, but it is also cost effective. Researchers to pull together their data with the clinical data. Developers, the pharmaceutical industry, the medical device industry, to share, to some extent, I understand there are commercial interests there, their data sets. Consumers and marketeers to share data on patient behavior and scientific data. And governments to share data on population health and public health data. And again, Mr. President, your government has collected tremendous data sets through the Turkish Health Survey. You conducted this survey back in 2013, and you're repeating this survey in 2018, but no Turkish researcher has access to this data set. It's a very well-kept secret. So you have to convince your statistical service to offer access to the Turkish research community to the Turkish Health Survey data so that they can produce high-quality academic papers. So we need to have an educated health data knowledge to make informed policy questions and develop technologies to meet big data privacy challenges, because our patients will always challenge this process, and always think that how we structure and analyze data is equally important to the quality of data we are using, asking the right questions and having the right data sets. In the next 10 to 30 years, technological, therapeutic, and big data advances are going to transform patient care and our healthcare systems. However, we should never forget that the most important factor in improving health outcomes is the doctor-patient relationship, is the fundamentals of medicine. Listen to your patient. He is telling you the diagnosis. Thank you for your attention.
Thank you, Professor Elias Mossialos, for such an inspiring presentation regarding big data in healthcare, promises and challenges. Çok değerli katılımcılar, soru alamayacağız çünkü vaktimizi bayağı aştık. Diğer konuşmacılarımıza da vakit kalması açısından. Ancak Elias'la mail üzerinden iletişim kurabilirsiniz. Şimdi Elias'a ödülünü vermek istiyoruz. Hediyesini vermek istiyoruz.